So, true cyst. What is a true cyst? So, what is a true cyst? A true cyst will have an epithelial lining. So, a traumatic bone cyst is not a true cyst because it doesn't have an epithelial lining. A traumatic cyst is found mainly in younger people and is asymptomatic. Appears as a radiolucency that scallops around teeth roots. Teeth are usually vital, no treatment necessary. Now, a globulomaxillary cyst is a developmental cyst found at the junction of the globules and maxillary processes of the maxilla between the lateral incisor and the canine roots. Globulomaxillary. This cyst arises from cells in a fissural line of the bone. So, there's many cysts, and how do you differentiate between a true cyst and a not true and a false and non-true cyst is the lining. A traumatic cyst will not have lining. Trauma in young kids, lack of motor coordination. Trauma in young kids, lack of motor coordination. Percentage of kids with trauma. Percentage of kids with trauma, it's about 22%. 21%, 22%, yeah. Plaque index used to motivate. Plaque index is used to motivate. So plaque index is used for patient motivation. Okay. And we're going to do here, write it down. Motivate the patient. Okay. Plaque index used to motivate the patient. Next, measure arch length, the mesial surfaces of the first permanent molars. So the measure arch length, mesial surfaces of the first permanent molars. Performing a mixed dentition analysis, you measure the mesodistal diameter of the mandibular incisors and add them together. Measure the space available for the mandibular incisors. Subtract number 1 from number 2. A negative number indicates crowding of the incisor region. Measure the space available for the canine and premolars on each side of the arch. Calculate the prediction table. From the prediction table, the size of the canines and premolars. Subtract number 6 from number 5. On each side. Again, a negative number indicates crowding. For the maxillary arch, mandibular incisors are used to predict the size of maxillary canines and premolars. Next, for dentists to avoid a lawsuit, he needs competence. A dermatologist refers a patient suspecting intraoral cysts, which disease that is one with pigmented lesions and also has can look like intraoral cysts. It's a nevoid basal cell carcinoma or Gorlin syndrome. Nevoid basal cell carcinoma. Or Gorlin syndrome. Next, acronym or non, oh no, I'm sorry, acron or non-acron articulator. So the acron versus non-acron. Acron articulator or non-acron articulator. The non-acron semi-adjustable for fixed partial dentures and removable partial dentures is a non-acron. Acron resembles the TMJ. It's used for the diagnosis of TMJ diseases. There are two members of the articulator, the upper chamber and the lower chamber, with a condyle. So when condylar segment is attached with the upper chamber is called non-acron, where opposite of it is called archon. So when the condylar segment is attached with upper chamber is called archon. So archon versus non-archon. Let's see an image. What is the difference between an archon and a non-archon? In an archon designed articulator, condylar housings are built into the upper membrane of the articulator, and the condyles are always fixed onto the lower membrane of the articulator. This design simulates the simulation of the condylar ball for the patient. With a non-archon designed articulator, the condylar housing is found on the lower membrane of the articulator, and the condyles are attached to the upper membrane. This design is opposite to the anatomy of the human skull. And we'll see an image. So a archon, the condylar articulator or non-archon articulator has anyway, so it's basically the location of the condyle. A non a In an archon, the condylar element attached to lower membrane and condylar guidance attached to the upper membrane. In a non-archon, the condylar element attached to the upper membrane and the condylar guidance attached to the lower membrane. I wish I could see an image. So Archon attached to lower membrane and condylar guidance attached to the, well, anyway. So Archon versus non-Archon.
Welcome to the University of Michigan Dentistry Podcast Series.
I'd like to show the skull to remind ourselves what the guidances on the skull are. We remember that the protrusive movement shows the mandible, the condyle, and the disc guiding on the infratemporal fossa, and in lateral excursions does the same but slightly to the medial. The guiding surface is on the upper portion, or in the skull itself, in the infratemporal fossa, and the mandible has the condyle and the disc. Now, if we use this to compare articulators, we would first of all look at the condylar type of articulator. The condylar articulator has the opposite of the skull, as we discussed before. This Hanos semi-adjustable articulator has the articular ball on the upper member of the articulator and the guiding surface, or the housing, on the upper member of the articulator. In contrast, we have an Archon type of articulator in which the condylar ball is on the lower member of the articulator and the guiding surface is on the upper member, as is the skull. You can look at this from the posterior to see the difference. The ball here rides on a flat surface in making articular movements, and the ball on the non-Archon instrument, or the condylar instrument, rides in a tract. Now, if we look more closely, we will see that when the condylar type of articulator is opened and we place an object in the molar area, for example, something that would be rigid such as hard wax, we see that there is an opening at the incisal pin, but in the area of the condyle, the ball is contained within the tract, or the guidance. Now, if we look at the Archon type of an instrument, in which the articulator, the top member of the articulator, comes off very easily and has to be handled carefully, if I place a hard object in this molar area, you can see that the incisal pin, or perhaps the condyle, will not seat in its fossa or on its guiding surface. So we must be careful when waxing up with the Archon type of instrument that we are sure that the condylar elements here are seated firmly and positively when doing any work, either when moving the articulator in the various lateral excursions, or when doing a wax up, for example, in a molar area. Now, going one step further and comparing the Hanoff to the whip mix, we'll first look at the...
Okay, so Akron is a articulator that resembles mostly the condyle. It's exactly the same as the condyle. And non-Akron is not. So let's finish this video.
Hanoff and look at the intercondylar distance. As we've noted before, the distance between the condylar elements is fixed, and it is an average measurement of 55 millimeters. Now, in contrast, looking at the intercondylar distance of the Rqs type of an articulator, we see the S, M, and L signifying a small, medium, and large. Now, this intercondylar distance can be varied. When they're together at the narrowest part, this is small. This can be unscrewed and placed in the medium position or the large position. Correspondingly, if we change the position on the lower member of the articulator from small to medium or to large, we must then use a spacer on the upper member of the articulator interposed between the condylar guidance and the upper member of the articulator proper. If I put one spacer in, it would be the medium, and if I would put two of these spacers in, it would be the large. It would accommodate the large intercondylar distance. Now, how do we determine this difference, this small, medium, or large, from the patient to the articulator? The whip mix face bow is the instrument used to determine whether the patient is a small, medium, or large, has a small, medium, or large intercondylar distance. This face bow actually uses the external auditory meatus to position the earpiece of the face bow, and it is self-centering. Now, we know the principle of the face bow, and we're not going to dwell on that. But you would take that reading from the patient, and it would, in the scale on the anterior crossbar of the face bow, will tell you whether the patient is of a small, medium, or large intercondylar distance. This is the medium position, the large position, and the small position. Now, this is, again, an approximation of intercondylar distance, but it is more accurate than using just the average 55 millimeter condylar distance. This little bit of refinement in being able to set the intercondylar distance allows this instrument to accept some lateral check bites. In review of determining the condylar settings of the Hanoff articulator, both the horizontal condylar setting and the vertical condylar setting, we remember that we positioned the wax bite between the stone cast in the protrusive position and then manipulated the condylar mechanism, the horizontal condylar mechanism, until the cast seated perfectly in the wax bite. We then secured that and determined that as being our horizontal condylar inclination. The vertical condylar inclination, or lateral condylar inclination, was set through the use of the formula h over 8 plus 12, which is the horizontal condylar inclination over 8 plus 12, giving us a setting to be set on the vertical axis indicator. Now, the Archon instrument, the Whitmix instrument, as determined by the manufacturer, recommends that the articulator be set from a lateral wax bite. When we look at the skull, we see in position a lateral wax check bite. Remember the protrusive wax check bite, we allowed the jaw to come straight forward into a protrusive position, and we captured that position in the wax. The lateral wax check bite, as you can see, the diamond.
Okay, so next we need to review more about articulators. So frequent urination in pregnant women, pressure of the bladder. Antifungal torches, clotrimazole. Treatment without consent, battery. Charging full mouth X-ray as separate is known as unbundling. 3 mm subgingival composite. I don't know what the question is. Subgingival composite.